Welcome to the deep dive. Imagine, if you will, your digestive system, your stomach, your intestines. It's like a busy city. And it absolutely relies on its road network, to get food energy in and waste out. If that traffic stops flowing, well, everything just grinds to a halt.
That's a great way to put it.
Yeah.
And today we're talking about when that exact system, the blood vessels feeding your gut, runs into trouble.
We're diving into diseases of the mesenteric arteries and veins.
Right. Arteries are those highways bringing the blood in, veins are draining it away. Problems here can cause really serious issues.
And we've been looking closely at the source material. These are important guidelines put together by medical experts. They help doctors manage these conditions.
Yeah, and our job today is really to unpack that expert knowledge for you, the listener, whether you're facing this yourself, caring for someone who is, or you're just interested.
Because understanding these conditions is so important, right? They can be, tricky to diagnose sometimes.
Absolutely. Knowing the potential signs, what diagnosis involves, what treatments look like, that knowledge is power.
Okay, so let's quickly map out this internal road network. You've got the aorta, the body's main artery.
The superhighway.
Exactly. And branching off that, you have major arteries heading to the gut, like the superior mesenteric artery, the celiac artery.
These are your main intestinal highways. They then split off into smaller and smaller roads.
And running alongside are the veins, doing the collection work, taking blood back.
And crucially, the body has these built-in detour routes, collateral vessels. If one main road gets a bit blocked...
Like roadworks?
Kind of. These smaller roads can sometimes pick up the slack, keep things moving, at least for a while.
Okay, so what kind of traffic jams can happen here? The sources mention a few main problems.
Yeah, you can get a complete blockage in an artery. That cuts off the blood supply. That's called ischemia. Think total gridlock.
Or you can have a clot blocking a vein, so the drainage is blocked.
Right, that's thrombosis, like a blocked drain pipe.
And then there are weaker spots.
Less common, yeah. Weak spots in the artery walls that bulge out those are aneurysms, like a pothole that could burst. Or even tears in the artery wall itself, which are called dissections.
And the sources make a really key distinction between problems that happen suddenly.
Acute problems, urgent.
And those that build up slowly over time. Chronic problems.
And that difference, acute versus chronic, completely changes the symptoms and, how urgently doctors need to act.
Makes sense. Let's tackle the acute ones first then, the emergencies.
Good idea. The big one is acute mesenteric ischemia, or AMI.
Okay.
This means a sudden, really severe cutoff of blood flow to the intestine, and the sources say this can happen incredibly fast.
That's fast.
Sometimes within minutes, maybe if a clot travels from, say, the heart and gets stuck, or it could be over a few hours if a blockage forms right there in the artery.
And the main symptom?
Intense abdominal pain. Really severe. And here's something the guidelines really stress.
What's that?
This pain often feels much, much worse than what a doctor might find just by pressing on your belly. It's sometimes called pain out of proportion to physical signs.
Wow. Pain that feels worse than it looks. That sounds like it could be easily missed.
It definitely can be. It happens because the bowel isn't getting oxygen and it's in distress long before obvious physical damage might show up on an exam.
And what causes this sudden blockage?
Could be clots from the heart, especially if you have conditions like atrial fibrillation or blockages building up from plaque atherosclerosis, or sometimes just really low blood flow overall in the body, like in shock, even a tear in the artery wall.
And the risk if it's not treated fast.
It's serious. The intestinal tissue can start to die, leading to, potentially fatal complications like infection or the bowel bursting. Speed is absolutely essential.
So how do doctors diagnose it quickly? What do the experts recommend?
Imaging is critical, specifically a type of SIAS scan called a computed tomography angiography, or CTA. The guidelines strongly recommend getting this scan fast if AMI is suspected.
Even if there are other worries, like maybe kidney issues with the scan dye.
Yes. The source material indicates that the priority is confirming or ruling out this life-threatening condition. Saving the bowel, saving the patient's life, outweighs those potential risks in an emergency. A high level of suspicion is needed.
Okay. Diagnosis made. What's the treatment?
Two main goals. Get the blood flowing again, ASAP, and then figure out how healthy the bowel is.
How do they get the blood flowing?
It can involve open surgery going in to remove the clot or bypass the blockage, or increasingly minimally invasive techniques using catheters and wires inside the blood vessel itself to open it up.
And you mentioned assessing the bowel. I saw something about a second look.
That's right. Especially if the blockage was severe or diagnosis was delayed, surgeons might plan to go back in, maybe a day or two after restoring blood flow,
Why?
to reevaluate the bowel tissue. Sometimes it's hard to tell immediately which parts are damaged beyond repair and which might recover. This second look helps them be sure they only remove what's absolutely necessary.
That sounds incredibly serious. Are there long-term consequences?
There can be. If a lot of intestine has to be removed, it can lead to something called short bowel syndrome. That might mean needing long-term nutritional support, sometimes intravenously.
That sounds tough.
It is challenging, but the guidelines do mention that even with short bowel syndrome, a moderate to good quality of life is often possible with the right support and management.
Okay, let's shift from blocked arteries to blocked veins. Acute mesenteric venous thrombosis.
MVT, yes. A sudden clot in the veins draining the intestine.
Similar symptoms.
It also causes abdominal pain, but maybe not quite as sudden or severe as the arterial blockage. Sometimes the pain might have been bothering someone for days, even weeks, before they get diagnosed.
Diagnosis still a CT scan.
Yes, a CTA is, again, the key tool. Experts recommend using scan settings that are optimized to see clots in the veins clearly. That's a Class 1 recommendation, meaning strong agreement.
And treatment for a vein clot. Different from an artery clot.
Generally, yes. The main treatment here is usually medication to thin the blood anticoagulation,
To dissolve it.
primarily to stop the clot getting bigger and allow the body's own clot-busting systems to work on it over time. Plus supportive care, of course, pain relief, fluids. Surgery is much less common, usually only if there are complications like dead bowel tissue.
Got it. There was one more acute type mentioned. Non-occlusive mesenteric ischemia. NOI. That sounded different.
It is. With NOMI, you get reduced blood flow to the gut, but without a physical blockage in the main arteries or veins.
So, the pipes are clear, but the water pressure is too low.
That's a pretty good analogy. It often happens in people who are already critically ill, maybe in intensive care, in shock from severe infection or heart failure, or after major surgery.
Why does the gut lose flow then?
The body, in these extreme situations, tries to protect the brain and heart, so it redirects blood flow away from less immediately vital areas, like the gut. Sometimes the gut vessels themselves can spasm, or very high pressure inside the abdomen can squeeze the vessels.
That sounds difficult to diagnose if there's no obvious clot or narrowing on a scan.
It can be very tricky. The sources mention that sometimes a more specialized X-ray test, digital subtraction angiography or DSA, might be needed. This actually watches the dye flow through the vessels and might be more reliable for NOMI. That's suggested as a Class 2A recommendation, meaning it's reasonable to consider.
And how do you treat it if there's no blockage to fix?
You have to treat the underlying cause. So, improve the patient's overall circulation if they're in shock, manage the heart failure, etc. And managing pressure inside the abdomen is crucial.
Pressure inside the abdomen.
Yes, intra-abdominal hypertension. Experts strongly recommend monitoring this pressure in patients at risk and taking steps to lower it if it gets too high to prevent LMI. That's a Class 1 recommendation. Sometimes specific drugs might be given directly into an artery to help relax the vessels.
Okay, that covers the sudden emergencies. What about the problems that develop more slowly?
Yeah.
The chronic ones.
The main one here is chronic mesenteric ischemia, or CMI.
And this is usually caused by...
Usually plaque buildup atherosclerosis in those main gut arteries, just like it happens in the heart or legs.
Well,
And remember those collateral vessels, the backup routes? Because of them, you often don't get symptoms until things are quite advanced. Usually, at least 2 of the 3 main gut arteries need to be significantly narrowed or blocked before you feel it.
so the body compensates for a long time. What are the signs when it finally can't cope?
The absolute classic symptom is abdominal pain that reliably starts after eating, usually within, say, an hour or so.
Predictable pain after meals.
Exactly. And because eating brings on the pain, people often develop a fear of eating. They subconsciously or consciously eat less and less.
And they lose weight.
Significant weight loss, often unintentionally. That combination pain after eating, weight loss is really the hallmark of CMI. You might also get nausea, sometimes vomiting, or changes in bowel habits, but the pain and weight loss are key.
Okay, so if someone has that pattern, how is it diagnosed?
The first test often recommended, a Class 1 recommendation in fact, is a duplex ultrasound. It uses sound waves to look at blood flow in the arteries. It's non-invasive.
And if that suggests a problem?
Then usually a CTA, the CT scan angiography, is recommended, again, Class 1. That gives a detailed map of the arteries, shows exactly where the blockages are, how severe they are, and helps plan treatment.
What are the goals of treatment for this chronic condition?
Primarily, relieve the symptoms, stop the pain, allow the person to eat normally again, regain weight, and also, importantly, prevent it from suddenly getting worse and turning into an acute emergency like a bowel infarction.
How do they fix the blockages?
It's called revascularization restoring blood flow. Two main ways. Open surgery, where a bypass is often created around the blockage.
Like a heart bypass.
Very similar concept. Or endovascular treatment, using balloons and stents inserted through catheters, usually from the groin or arm, to open the artery from the inside.
Is one better than the other? What do the sources say?
They compare them. Open surgery tends to last longer, the bypasses stay open better over many years, and symptoms are less likely to come back. But it's a bigger operation, higher upfront risk.
And the endovascular way?
Less invasive, lower initial risk, quicker recovery usually. But there's a higher chance the artery might narrow down again over time, meaning you might need another procedure down the road.
So it's a trade-off.
It really is. The guidelines say both should be considered. Class 1 recommendation. The choice depends on the specifics of the blockages, your overall health, what you can tolerate, and importantly, discussing those pros and cons. Shared decision-making.
And if they do the endovascular option?
Using a stent, a little mesh tube to hold the artery open, is generally recommended over just using a balloon to stretch it. That's another Class 1 recommendation.
And after the procedure, whatever type?
Lifelong medical management is key. Things to tackle the underlying atherosclerosis statins for cholesterol, often aspirin or similar antiplatelet medication. Lifestyle changes too.
Okay. What about those bulges, the aneurysms?
Right, mesenteric arterial aneurysms. These are quite rare compared to blockages. They're weak spots that bulge out.
Do they cause symptoms?
Often no. They're frequently found by chance on a scan done for something else. A CTA is the best way to diagnose them. Class 1 recommendation.
If they don't cause symptoms, what's the worry?
The big risk is rupture. If they burst, it's a massive internal bleed, extremely dangerous, causing sudden, severe pain. There's a specific type called a pseudoaneurysm, often linked to things like pancreatitis or injury, that the sources note has a higher risk of rupturing.
So when do they need fixing?
It depends. Is it a true aneurysm or a pseudo? How big is it? Where is it located? Are there symptoms? Pseudoaneurysms are often treated regardless of size because of that higher risk. Class 2B recommendation, meaning maybe considered.
And true aneurysms?
For true ones without symptoms, small ones might just be watched with repeat scans, but once they reach a certain size, say around 25 millimeters, treatment is often considered to prevent rupture. Class 2A recommendation, reasonable to consider.
What are the treatment options? Fixes?
Again, it can be open surgery to repair or bypass the aneurysm, or endovascular methods. Things like filling the aneurysm bulge with tiny coils, or placing a covered stent across it to seal it off from the inside.
Is one preferred?
The goal is usually to block off the aneurysm but keep blood flowing through the main artery if possible. Class 1. Endovascular repair might have lower upfront risks than open surgery. Class 2A.
Okay, one last category. Isolated mesenteric artery dissections. A tear.
Exactly. A tear in the inner layer of the artery wall. Blood gets between the layers. The sources say this is less common than blockages, often seen in slightly younger people, more often men, and frequently linked to high blood pressure. The SMA, the superior mesenteric artery, is the most common site.
Symptoms?
Can be sudden, severe abdominal pain, or, interestingly, sometimes they cause no symptoms at all and are just found incidentally.
Diagnosis again with?
CTA, it's really the workhorse for imaging these vessels.
And how are dissections treated? Is it always surgery?
Actually, no. Many patients, even with symptoms, can be managed conservatively. That means careful blood pressure control, maybe blood thinners. Intervention like stenting or surgery is usually only needed if there are complications, like signs of poor blood flow or if pain doesn't settle.
But follow-up is important.
Yes, definitely. Because there's a small risk the artery could narrow later, or an aneurysm could form at the site of the tear. Follow-up imaging is recommended. Class 2A.
You know, listening to all this, it really highlights something the guidelines touch on the patient's perspective.
Absolutely. Doctors often focus, understandably, on technical success. Did the stent stay open? Did the bypass work? But for you, the person living with this,
It's about quality of life.
exactly. Can I eat without pain? Did I get my energy back? How does this affect my daily life? That's the ultimate measure of success.
Which makes the decision-making process, especially for the chronic conditions or the aneurysms that aren't immediate emergencies, really important.
It's crucial. Shared decision-making. Having that conversation about the risks, the benefits, the uncertainties of different options, and what matters most to you considering your own life and values. That's key. Obviously much harder in a true emergency situation.
And speaking of getting the right care, the guidelines had a strong point about where to get treated for complex cases.
Yes, a Class 1 recommendation. For complex conditions like chronic mesenteric ischemia, evaluation and treatment should ideally happen at specialized centers.
Why is that?
Because these centers have the whole team: vascular surgeons, interventional radiologists, gastroenterologists, dietitians, everyone needed. They can offer both open and endovascular treatments and have the experience to manage these complex situations best.
Right, access to the full toolkit and the expertise to use it.
Precisely.
So wrapping up this deep dive then, mesenteric artery and vein diseases, it's quite a spectrum, isn't it? From sudden life-threatening emergencies to these chronic issues that build up over time.
It really is. I think the key takeaway for listeners is recognizing those potential symptoms, especially that abdominal pain if it's severe, if it's unexplained, or particularly if it happens reliably after you eat, maybe with weight loss you can't explain.
Don't ignore it. And getting the right diagnosis often hinges on getting the right imaging quickly. That CCAT scan, the CTA, comes up again and again.
It's vital. And for the more complex chronic problems, seeking out care at those specialized experience centers can really make a difference. That's what the experts recommend.
Because these aren't simple conditions, and the best treatment plan is always going to be personalized.
Absolutely. It depends entirely on the specific problem and your overall health.
Comes back to that hidden highway system inside you. It's working away quietly, usually.
Hopefully.
But paying attention, if your body sends up a flare, that unusual pain, the weight loss, that's the first step to keeping those highways open and flowing smoothly. Definitely talk to your doctor if you have any concerns.